We finally got all our technical issues. I don't have any clue, but we finally got it going with the help of all these guys here and gals. Well, we're going to talk about dying. And it's kind of an afternoon spent with, and I see familiar faces out here. How many medical people do we have? Well, we got students, case managers, social workers. How many lay people do we have? Everybody's, I see Rhonda over here, so I see a lot of familiar faces. So we really want to talk about the why, what, when, and where of palliative care and hospice. And we're going to explain what palliative care is, and we're going to explain how hospice is not palliative care. It is palliative care, but it's not exactly the same as palliative care. Hospice is a subset. We're going to talk about that. We're going to talk a little bit about medical ethics and how that relates to what we do every day. And we're going to talk about advanced care planning. So we've got quite a few slides to go through here. We've got 3 o'clock, is that right? Okay. Y'all stop me, raise your hand, ask a question. I'll try to stop after each little section, and maybe we can have a few questions, and then we can move on to the next section. See if I can push the right buttons. Side. Okay. So I just need to click on them here, I guess. This is just a pointer, isn't it?
No, it needs to. Let me put it in slideshow.
Okay.
Slideshow.
All right.
Now try.
Thank you, sir.
See if it works.
Is it up or sideways? Let's see, up or down.
Should be this one here. Well, we may have to use the
You have to use the arrows. That's fine. That's fine. Okay. All right, here's the simple definition of palliative care. It's really the care of patients with advanced progressive disease in whom cure is no longer possible. And it's a new medical and nursing specialty. It's actually been a specialty through the American Board of Medical Specialties now for about 10 or 11 years. So it's not that old. It's fairly new. Here's the growth of palliative care in hospitals in the United States. You can see the curve is pretty sharply upward. And nowadays, about 75% of all hospitals, more than 75 beds, 3/4 have a palliative care program of some sort. So the growth has really been quite tremendous, and it continues to grow. So here are the basic principles of palliative care. Of course, we focus on pain and other distressing symptoms. We affirm life and regard death as a normal process. Unfortunately, I don't believe our culture does that very well. Y'all see that a lot, I'm sure. We talk about psychological and spiritual aspects. I think you'll get a flavor as we go through this that, at least my belief, and I think palliative care believes, that dying is more than medical. In fact, it's probably not very medical. And that's one of the issues we have in dealing with patients who are dying, is trying to sort out what they want and what their goals are. We focus on the patient and the family. It's important to think about the family. It's not just the patient. We have a team. What's the old saying? There's 9 people on a baseball team, and you got to have all 9. So you got to have case managers and social workers and chaplains and nurses, doctors. So you got to involve everybody, or it's important to involve everybody. And we focus on quality of life and care burdens, and we're going to talk about care burdens. There are a lot of burdens of medical care when you're elderly, when you're chronically ill, or when you're terminally ill for sure. Palliative care is appropriate at any time in any life-limiting illness, so there's no limits on time. It's not like hospice where you need to have 6 months or less. So you can do it really at any point in a patient who's chronically ill. And we respect patient choice, preferences, and values. That's a very important tenet in palliative care. So why do we need this new medical specialty? Well, we have an aging population. Well, they call it the silver tsunami. I've seen about, in the last couple of days, 4 or 5 new consults at Park West. 2 of them are 95, 2 of them are 100. So we see a lot of elderly folks that need palliative care. And then we have a fragmented, specialized medical care system today. We've got doctors for every organ and every body part, right? But we don't have doctors, at least we don't have enough of them, I don't believe, that focus on the patient, the whole patient, if you will. And then I practiced internal medicine for 28 years. I started when I was 12, by the way. I'm not that old. And most of that time, 26 out of the 28 years, I went to the hospital and saw my patients who were hospitalized, at least at St. Mary's, where I practiced most of all that time. Nowadays, primary care doctors don't go to the hospital, or very few do. It's very rare nowadays. So we have hospitalists who take care of patients who don't know the patient, they don't know the family. So there aren't any Marcus Welbys left, not many. Maybe a few, but not many. And then we have fee-for-service medicine. How do doctors and hospitals and medical folks get paid? They get paid to do things. They don't get paid to sit down and talk to you about what you want and you don't want. Or they certainly don't get paid to sit down and tell you you're dying, and that's hard. And nobody wants to do it. And then we have cultural factors. Americans think death is optional, right? You've heard the old saying that the Englishman thinks death is inevitable, and the Irishman thinks death is imminent. That's why he goes to the pub every night and has a good time. But Americans think it's optional, and you can hold it off, you can maybe delay it, maybe you can even avoid it completely. And then we have physician factors. Physicians don't handle it very well either. Physicians are control freaks. Anybody disagree with that? We like to control things. And we sure don't like to give up. If we give up easy, we wouldn't have made it through school. So it's hard for doctors to talk about death, particularly if your patient is someone you've known. The longer you know the patient, the harder it is to talk about death and dying. I've experienced that as I've seen some of my old patients who I knew for many years in my new role as a palliative care doctor. I've experienced how difficult it is to talk to people about death, particularly if you know them. It's harder, actually. You'd think it'd be easier, but it's harder. And then we must not bury our head in the sand. Medicine is costly, and much of medical care, in fact, I think the statistics are something like 5% of Medicare patients spend 2/3 of the Medicare cost in the last year of life. When you look at those statistics, we have to realize that a lot of care is not important, not necessary, or even futile near the end of life. So palliative care is the best way to approach that, at least in the current system. So there's lots of good reasons why we're a new specialty. So what do we do when we see a patient? The bread and butter of palliative care is discussing and clarifying goals of care. You would think that's pretty obvious. When you come to the hospital, you'd like to get better, right? That's obvious. We want to get better. We want to return to our previous quality of life. But what if you're terminally ill and you don't have much quality of life? When you come to the hospital, unless you clarify the goals, they're going to do everything to you that they do to everybody else, you see? So sitting down with patients and families, talking about options, talking about hospice when it might be appropriate, is the bread and butter of what palliative care does. Of course, we help with pain and other symptoms. We talk about advanced care planning and how important that is, particularly if you're terminally ill. We explain hospice, better early than late. Everybody's heard the statistics probably, or y'all have heard that 1/3 of hospice patients stay on hospice. How long you think? Months? Days? 3 days. 3 days or less, 1/3. A half stay on hospice 2 weeks or less. And then the last one here is very, very important. Realistic prognostication. I would underline realistic. And recognition of the dying process. At the same time, you have to talk to people about the dying process and some general idea about prognosis. You also must be sure they understand that no one can predict timing of death. It's like trying to time the stock market. Can't do it. It's impossible. However, you don't need to use that uncertainty to never talk to people about dying, because they need to know they're dying, or at least have some idea what's going on before they can change their goals. So that's very, very important. We're going to talk about how to do that. So here's the thing about goals of care. Alignment of goals is very important, has many benefits. Focusing on disease control only leads to more pain, more anxiety, more family exhaustion, as well as more non-beneficial care and more hospitalization. And the reality is, these patients don't live longer, at least in many cases. Here's a pretty controversial statement. If you read this at a medical staff meeting, you might get some boos or some hoo-hoos or haws. What are you talking about? The view that palliative care is only appropriate after all possible disease-modifying therapy, which is prevalent among the medical community and public, is harmful and incorrect. What do you think about that statement? The medical community, many doctors think that palliative care is something you do after you've done everything else. And I hope when we get done today, you're going to realize that that's not what it's about. It's about helping with that transition, really. So clarification of goals of care requires realistic prognostication, recognition of the dying process, and communication skills, as well as time. You know, I was practicing primary care. You've got 25 patients to see, and you've got a busy day, and you might have, go to the hospital and make rounds. And if you sort of say, well, I really need to talk to Miss Jones, who's 85 and got end-stage heart failure, about death and dying and what she wants and doesn't want, but I think I'll put it off till the next visit, because I ain't got time today. It's very difficult to do that when a busy physician has limited time and they're stressed and they're trying to get through their day. So it's hard. So communication is very important. Sometimes hospitals need chairs more than they need any other. If I were giving money to a hospital, I believe I'd give money for them to buy chairs. Small chairs that you can sit down and talk to people. You'd be surprised how many rooms you go into and there's no chair. And how often does the doctor go in and spend a short period of time, and they may give the patient good information, but they're standing up over them, and they look like they're rushed, whether they are or not. If you sit down on the level with the patient and talk to them for 2 or 3 minutes, they'll sense that you spent time with them. You must sit down. There's an old adage in medicine that, don't just stand there, do something. So we're all taught that in training, right? Just don't stand there, do something, do something. In palliative care, we say, don't just stand there, sit down and shut up and listen. So understanding and coping with a terminal diagnosis is not a one-time conversation. It takes some processing. People have to let it sink in. And it's hard for people to accept that, of course. And here's another thing I think is very important, particularly in relation to cancer and oncology. When you go see your oncologist, and maybe you have lung cancer and you're on your second line chemotherapy, and they're talking about the third line, and then sort of at the end of that option, the doctor sort of talks to you about how this is not looking good and things are getting worse, and you didn't respond well to the first 2 lines, but we've got this third option. What do you think the patient hears? They don't hear that they're dying, right? They don't hear that things aren't doing well. They hear, like all of us would want to hear, the positive aspects, the possibility that I could have another line of treatment. So these discussions need to be separated. And I think that's one of the things that makes palliative care so important in all terminal illnesses, but particularly in cancer. You separate the discussion between treatment and end of life. They need to be separated to some extent at least. And the oncologist can do that, but what they need to do is have a special, or the primary care doctor can do that, but they need to make a time. We talked today about your diabetes, your hypertension, and your heart failure meds. And we're going to make another appointment in a couple of weeks, and we're going to come back and we're going to sit down with you and your family, and we're going to talk about what's going on. We're going to talk about end-of-life issues. We're going to talk about what you want and don't want in light of the fact that your outlook might not be that long. So I'm not saying any doctor can't do it. It's just that we do it a little bit differently, and we separate those things out. Conversations should include the family, and of course they're time intensive. And some people say, well, I don't know how to do that. I don't know how to talk to people about death and dying, and it's not easy. But there are techniques. One technique is you have to ask patients what they know. That's one of the first things we usually do when we talk to patients. What do you know? What is your doctors telling you? One lady recently told me she was like a mushroom. They keep me in the dark and they feed me, you know what. Right? But I think it's important to ask them what they know and then gently tell them some information and then ask them what they understand, because you have to work your way into it. And another technique is I wish, I worry. And you know, we all have patients who say, well, what do you want to do? Well, you know, the doctor told me if I get stronger, I can have more treatment, chemotherapy, whatever it is. And so you might say something like, well, I wish you could have more treatment. But I worry if you go to rehab, you're going to spend the next 6 weeks trying to get rehab when it may not work, or it's a pretty good chance it won't work, and you're not going to get stronger. So you're going to miss the opportunity to spend 6 weeks at home, or 6 weeks wherever it is. Go to the beach for 2 weeks. So I wish, I worry is a good technique to use. You can sort of reinforce the patient's hopes. At the same time, you're worried that if you go down that path, that might not be the best way to go. At least make them think about it. So communication is very, very important. And you can develop these skills if you really want to do that. So what do you think patients and families want when they use the term death with dignity or a good death? What do people want when they're dying? What do you think? Got any idea? Free of pain, of course, yeah. That's right, yeah. I put in for that choice there. I don't know if I'll get it or not. That's true. Dying at home. That's right. That's important. Yeah, I think when you see a patient, when we see a patient in palliative care, if their pain's uncontrolled, nothing else matters until you get that control. I agree with you. You've got to have some semblance of symptom management before you can even talk about some of these things. But you're right, dying at home.
I think sometimes some people have higher anxiety standards than others. But the ones that, are lower in anxiety, they probably, want a peaceful death, accept whatever. Those of the high anxiety, just striving to live the last day possible. Yeah, I think it's a difference in personality.
Well, we paint things nowadays, particularly with cancer, as a battle to be won, right? It's like a war, and you're a soldier, and if you don't fight and you don't battle,
and I've been in that position, but I've been there with a primary care physician that said to the oncologist, he's had enough. He's had enough of all of these things that are supposed to be.
Yeah.
That was great, but I had that kind of advice.
Somebody who's willing to say that it's time to think about stopping all this. So here are the things that people say they want with a good death. One of the first things is that if I'm dying, let's get it over with. I don't want it to go on for a long time. Not prolong it. Pain and symptoms, of course. They want to be a burden to the family. A lot of people worry about their family more than they worry about themselves, right? They worry about that. And then they want control, some control over decision making. We're going to talk just at least a little bit about the Death with Dignity Act in Oregon here in a few minutes. And that's one of the things about that. People want control over their death, so that's one of the reasons they may sign up for that. And then strengthening relationships. So, there aren't any perfect families. If there are, I don't have one, and I haven't met anybody that has one, really. People have disagreements with children and spouses and, parents and co-workers, and if you're going to the doctor 3 or 4 days a week and getting radiation 2 weeks in a row and doing all these things that people do before they die, you don't have an opportunity to strengthen your relationships. So that's an important thing that people say they want time to do when asked. So here are some questions that we might ask a patient when their disease progresses. Do you have a living will, or we use the term nowadays advanced care plan or advanced directive? We need to ask that. I don't know how many times I've been told, well, I do, but I ain't looked at it in years. Or somebody told me this morning they lost it or they didn't know where it was. I get that. I lose things too. So what does it say about CPR? That's one thing to talk about. And who do you want to make medical decisions if you get where you cannot? And a very, very high percentage of patients who are terminally ill lose their capacity to make decisions. About 80% eventually lose their capacity. That's very, very important. Have you discussed hospice? Better early than late, and we'll talk about that. Are there family or spiritual issues to resolve? Or we may ask, is your faith important to you? And that kind of gets you down a path. Rhonda knows about all that and asking you about how that plays into your life. And then have you thought about where you want to die? Like you mentioned home. Some people don't want to die at home, but most do. And then this is an important question, I think, that makes people think. And, you know, I always say, I don't know how long you have to. Well, first of all, I want to ask people, do they really want to know how long they live? Some people don't want to know, don't want to talk about it. And that's okay. But if you did, if you thought you had just a few weeks or a few months, how would you spend that time? And then where would you want to spend that time? So these are things that make people think about what they want. They may not like that question at first, and it upsets people sometimes, but it's an important question to ask. So here are the burdens of care. There are lots of them in this modern medical world we live in. You think there's a pill burden in this country? Are you kidding me? How many people are on 20 pills a day? I mean, Lord gracious. There's a testing burden, particularly if you're very, very ill. You're going, you know, you're getting an MRI one day and a CT the next, and lab work the third day, and so forth and so on. Treatment burden. Just getting to the treatment is hard for a lot of people. And then this transitions to care burden. Home, hospital, nursing home, hospital, nursing home, funeral home. That's the way it works, unfortunately. And then there's a terrible decision burden. I don't know how many people I've seen that would like me to tell them what I think's the best. But no doctor will tell them. They don't want to tell them. They're afraid to tell them, or I don't know what's wrong with them, but why they won't tell them. But people sometimes want you to tell them. What do you think, doc? So people it's hard for people to make decisions. We throw things in people's lap. Do you want to be a DNR or full code? Do you want dialysis or not? Do you want a ventilator or not? It's like a menu. Let's order the steak and the potato and a dessert. Hospitals are like menus sometimes. We just ask people what they want. And they don't know what they want. They don't know what they need. I mean, it's sort of like we've abrogated our professional responsibilities sometimes, I think. And not that in palliative care we're trying to tell people what they want, but we're trying to give them information and advice and let them make up their mind. And then there's a symptom burden, of course. There's a caregiver burden that's terrible, really. A lot of people are caring for their relatives, and it's difficult. And then every medical decision includes a benefit and a burden, particularly if you're terminally ill. And you have to weigh that in your mind, I think. So here are the major causes of death in the United States. On the right, acute conditions. Of course, we've had people die of the flu and complications, but we don't have as many people dying of acute illnesses like we used to years ago. In fact, people with heart disease and so forth don't die suddenly as much as they used to. We've got defibrillators and all sorts of issues there that decrease that incidence of sudden cardiac death. So we still die of chronic diseases, but it makes then palliative care and talking about what you want and don't want and how much you're willing to go through and what kind of quality of life you're willing to endure more important than ever, I think. So this is a slide about where people die. You see hospital about half. That's actually decreasing in the United States, some. Home is up some, so 20% at home, 80% in a hospital or nursing home, and then you see where people say they want to die, home, hospital. Nobody ever wants to die in a nursing home, right? That's not their choice. So here's a slide that really sort of talks about where we're at. If people wish to die at home, why do most die in the hospital? Forces exist in our healthcare delivery system together with the values related to health and illness that propel the physician, patient, family towards aggressive life-prolonging care far longer than is medically appropriate. Such care is typically provided in a hospital up until shortly before death. This is the way it works. This is what happens a lot, whether the patient wants it or not. So why is that the case? And we've already mentioned this a little bit. We've got physician forces. Doctors have a personal fear of death and a fear of failure. They identify with the patient. We've already talked about how it's difficult if your patient is seen as a friend to stop aggressive care. And then doctors fear they'll miss something. If I didn't do this, somebody will blame me that I didn't do everything, if you will. And then patient and family forces. We have difficulty accepting death, as we've talked about. Miracles. Don't want to give up hope. Don't want to talk about death. And then personal weakness. Like we talked about, we paint everything as a battle. It's, you know, it's a fight. You know, I hear people say, I'm a fighter. Well, yeah, okay. That makes me think of a soldier on the front lines, you know, who's not going to last long. And in fear of the impact of death at home. Sometimes I hear people say, I don't want to die at home because I have small children at home. What do you think about that? You think it's a good idea to shield children from death? Is that a good idea? I don't think it is. And then failure to discuss advanced care planning. And then we've got system forces. We have a lot of hospital beds, but beyond that we have a lot of intensive care beds. The United States has more intensive care beds per capita than any other country in the world. And we use them. If you build it, they will come. And then we have a lack of organizational structures to support excellent end-of-life care in all settings. We don't have a residential hospice in this East Tennessee area anymore. We have one in Johnson City, one in Nashville, but not in Knoxville anymore. We don't have beds in a hospital where you can go die. We don't have palliative care beds, although we use places. We use 8 North at Fort Sanders, don't we? And we use 4 Riverstone at Park West, and we've sort of designated those beds, but we don't have a place. In my perfect world, we have intensive care units. Every hospital should have a palliative care unit, right? And it really should be proportional. If you got 30 intensive care beds, you ought to have maybe 7 or 8 palliative care beds. But hospitals they aren't set up for the dying, even though people die there all the time. Every day they die there, but they're not set up for that. That's not what they do. In fact, they just soon to bury that under the rug and forget about it, you see. And then we have financial disincentives that force us, as we've mentioned, fee for service and so forth, that forces us to do things when it no longer makes a lot of sense. So how do we move from this situation? It's very, very important, and probably the single most important issue, as this slide says, in good end-of-life care, is to recognize the dying process and name it. It's okay to say you're dying. It doesn't mean you're dying today, tomorrow, next week, next month, or even 6 months from now. But you must name the process. If you don't, there will be no timely transition away from curative or life-prolonging care towards palliative care. So how do we recognize the dying process? Disease trajectories are important. There's an old saying back where I come from in the country. I grew up on a farm. When you take to the bed, you're dead. It's as true today as it's ever been. So you see, let's see, I don't have a pointer, but you can see the top one, cancer. Let's look at the 3 main ways we die now. Well, there's more than that, but those are the three main for chronically ill folks. If you have cancer, you may be diagnosed with lung cancer and live weeks, months, or years, and you're functioning at a pretty high level. You can see up here at the top. And then you start declining, and when you get to spending about half of your time in bed, and you're losing weight, and your disease is progressing, you're dying. You might live a year or two, but you're dying slowly. Some more rapidly than others. But you can see the trajectory of cancer is quite predictable. Once you start the downward path, very few people turn back upward in their functional abilities. So that's why when we hear if I get stronger, I can have more chemotherapy. And y'all see this all the time. Y'all are, you're not going to get stronger in most cases. There's some exceptions to this. I'm not saying this is true 100% of the time. Nothing in medicine is true 100% of the time, right? There are always exceptions. But in most cases, a great majority of cases, when they start the downward track, they don't improve. And death is coming in a predictable period of time, whether it's weeks, months, or even, almost a year, but it's coming. And then with chronic heart failure or lung failure, you start often with some decline in your functional status when you get to that point, and then you have these exacerbations where the little dips. You see the second slide there on the right. And usually these dips are hospitalizations. Let's say you have COPD, and you come into the hospital back and forth, and you make a little bit of improvement, but you don't get all the way back to your baseline. Maybe one or two of these times you're on a ventilator, and you come off the ventilator. So people do this. Sometimes I've had patients, we count they've been in the hospital 10 times in 6 months, right? With COPD or end-stage heart failure. The problem is you can't predict which one of these episodes they're going to die. So sometimes I'll draw this out and say, here you are right here. We don't know if you're going to get out of the hospital this time or maybe the next time or which time. All I'm saying is let's think about what you want and don't want. Do you want to die in the hospital on a ventilator, or would you prefer to die at home on hospice? So these are things you give people choices. But you have to think and understand what the trajectory of disease is without being able to predict timing of death. You have to understand, at least in a general way, and the patient has to have some understanding before they can change. And so on the 6 o'clock news, I tell people, about 3 days a week, they cure cancer, so nobody is going to die of cancer, in about 30 years or maybe sooner. And then they cure heart disease and so forth. So the rest of us are just going to dwindle away. That's the final path down here. That's the dementia path. And you're in the bed and you live in a nursing home and you're on a tube feeding and you're back and forth to the hospital, but you just sort of decline. And that's the most unpredictable. It's hard to predict when a dementia patient's going to die. Anybody have questions about that? It's not easy to predict when someone's going to die, don't get me wrong, but you have to be able to name the process, and then it changes your goals of care. Once you understand that I'm down that path, or I'm on that journey, I tell people, I know when you're on the journey. I don't know when that journey is going to end, but I know you're on it. And let's think about what you want and don't want so we can prepare. Hope for the best, prepare for the worst. So this is that ICU patient that's got everything in the world going, dialysis, ventilator, pressors. Look at all the pumps over here going here. And all we can do is tell families that there's a pretty good chance that your loved one is not going to survive to discharge. We don't know that for certain. Some people do. And even if they do survive to discharge, they're not going to return to their previous quality of life. There are certainly exceptions to that. There are people who surprise us. But when you see this type of situation, you just have to think and sit down with folks and let them make a decision about what they want and don't want. And I often try to talk to families about, what do you think your mother would want in this situation? Did she talk about what she would want, even if she didn't complete an advance directive? And that helps families, I think, to begin to think, what would my loved one want? But it's difficult. So we've talked about this as what is dying, and the top line there is really just the Webster's Dictionary, gradually ceasing to exist or function, in decline and about to disappear. Of course, we use euphemisms. You read the obituaries in the paper, nobody died. Everybody went to heaven, or what are the other, y'all know what all the euphemisms are, but passed away. Nobody died. I mean, you know, there's a few now who are putting that. Once in a while I'll see that, but not very often. So as we mentioned, we all avoid discussing dying. And that's, you know, a minority of the population have actually seen death or witnessed people dying now, as opposed to 50 years ago, people died at home and they witnessed it. Some people say part of our avoidance of death is that we don't even see animals die anymore. You know, we're all city dwellers, or most of us, and we don't grow up on a farm where, you know, calves die and they're, you know, and so forth and so on. So we live in a different society. And then we already mentioned that Americans consider death optional. How are we doing on time? So now we can say you are dying when you have a chronic life-limiting illness and you're progressively losing function and or weight despite best medical therapy, using increasing medical resources with no improvement. That is, you're coming back and forth to the hospital and you're not improving. Or if the patient has requested no further measures to reverse current or future medical problems. The dementia patient who doesn't want, or the family doesn't want, to treat the next pneumonia, for example. So it's okay to use the term dying. And then we use this thing called a Padley Performance Scale, which takes into account not only disease activity, but your ability, you know, whether you're bedbound or not, how much ambulation or activity you can do, how much self-care you can do, and then your intake. So sometimes in the hospital we see patients that we are not going to move out of the hospital. We'll say their Padley Performance Score is 10%. And you can see down here they're totally bedbound, unable to do any activity, extensive disease, they require total care, and they're getting mouth care only. That is, they're on comfort care and they're not getting IV fluids or tube feeding. So these patients generally have a prognosis of days or less, even though actively dying patients like this can live for a week or two. But we use a thing called a Padley Performance Score or scale. And as we mentioned, doctors often paint things in an either-or fashion. So this doctor's telling the patient what fits your busy schedule, exercising an hour a day or being dead 24 hours a day. The irony of that is that, you know, doctors don't want to talk about hospice, and they don't talk to people in a timely manner about hospice. But if you say, I don't want that pacemaker, or I don't want that bypass, or I don't want that stent, or I don't want that chemotherapy, even if you're up and about and active or even working, they may say, well, you just need to go to hospice. So people just, sometimes if you don't do what the doctor wants, the psychology of it is, well, okay, you just need to, if you're not going to do what I want, or if you're not going to do this procedure or whatever it is, you're going to die, so just go to hospice. So this is the way we sort of paint things. I think it's interesting how that works sometimes, even when they're not appropriate for hospice. So let's switch gears and talk about hospice. So palliative care, any questions about what's palliative care about? Everybody knows what palliative care is now. Yes, ma'am.
I sort of have a question about how the referral process is, if you discuss it.
Well, we have to have a physician referral to do palliative care. And understand that much palliative care in the United States is still focused on the inpatient environment. There are some outpatient palliative care, and we have some in this community, and it's growing, but it's not extensive. So most palliative care is an inpatient, requires a physician consult. We are consultants only. We don't take over the care of anybody's patient, although our role becomes more important near the end of life. But yes, ma'am.
So is the palliative care physician one that is automatically referred when we know that this is what's going on? So if my dad is really sick and he's in the hospital, so are you or someone like you going to come see him, or do we ask for that?
You can ask for it. Families ask for us quite often nowadays. It has to come from a physician. So you could say, you know, don't you think we ought to ask palliative care to come and see my dad, or patient,
And
yeah.
then if they wanted to stay in the hospital, can you request palliative care inpatient?
Well, part of what we would do is see the patient and try to figure out whether it's appropriate. You know, if a patient's actively dying, has short prognosis, we may keep them in the hospital. But generally, we're going to look for options outside of the hospital: home hospice, nursing home with hospice, assisted living, and so forth. Yeah. And it's difficult sometimes to make a decision whether you're going to move a patient out of the hospital or not. Generally, actively dying patients are those that we think have a very short prognosis. We may not move, but you can't keep somebody in the hospital 2 or 3 weeks, you know, who has that type of prognosis, yeah, or if we think they do. So let's switch gears and talk about hospice. How many of you have had a family member on hospice? Quite a few of you, a lot of you have. So a lot of people don't understand hospice, and a lot of doctors don't understand hospice and how it works. It is a daily fee, all-inclusive program. That is to say, hospice gets, for most hospice care, routine home care, they get about $160 a day, which pays for everything related to your end-of-life care. And it used to be it only covered the primary diagnosis. Actually, they're trying to expand that into some of the comorbidities. So if you're on hospice for congestive heart failure, let's say, and you're on Lasix, you're on an ACE inhibitor, you're on a beta blocker, those drugs are covered by hospice related to your primary hospice diagnosis. They also cover a hospital bed, they cover oxygen, they cover social services, they cover chaplains, they cover nursing visits, they cover home health aide visits. So they have to pay for all of that. Generally, when you go on hospice, you've accepted the goals of care, mainly care and comfort. That is to say, you've decided, I don't want to go back to the hospital for the next episode of shortness of breath. I'm going to call hospice rather than call 911 or go to the hospital. Although people panic and do that. They come off hospice sometimes. Sometimes they stay on it, but at any rate, generally when you accept hospice, you've accepted their philosophy of care. You have to have a prognosis of 6 months or less. However, that's hard to predict. So people stay on hospice longer than that. There is no limit to the benefit. We have patients that stay on hospice 2 or 3 years. Now we have to show decline, and hospice has what's called benefit periods. The first 2 are 90 days. So when you go on hospice, you have to have 2 doctors say that you have a prognosis of 6 months or less. And the way it's worded is if the disease runs its normal course. So it's usually your primary care doctor or your specialist, maybe it's your cardiologist. They sign a form that says you have prognosis of 6 months or less. Then after 90 days, you're on hospice, and let's say you're better or you're stable. Sometimes you get discharged from hospice and you come back later. If you decline, you'll be recertified for the second benefit period. And after 180 days, after 6 months, the benefit periods are every 60 days. And you have to have what's called a face-to-face visit, which is a physician or a nurse practitioner. And as of this week, President Trump signed a bill that said physician's assistants can actually work in hospice, which has not been allowed, which I think is interesting. So you have to have a visit in their home, and I'd make those visits pretty regularly. And we make a decision based on weight loss, based on arm circumference, based on decline in the palliative performance score that we've shown, and there's a couple other scales that we use. So we're just trying to make some educated, as you say, guess about, if they're declining, they'll stay on hospice. So that's kind of the way the program works in general. Hospice has been around since 1982 when President Reagan signed the Medicare Hospice Benefit Law. It's part of Medicare. 85% of all hospice patients are Medicare, by the way. Great majority are Medicare. Small percent, about 15%, are private insurance. TennCare, Medicaid, private insurance, all private insurances has some hospice benefit, or I guess there might be some who don't, but most do. Right, ladies? Y'all see that. Hospice has had tremendous growth. You have over 5,000 hospice agencies in the United States. By the way, about 60% of those are now for-profit hospice agencies. Less than half are not for-profit. You have some very large companies in the United States that are involved in hospice, and hospice is a growth industry with 40% of all Medicare deaths now are on hospice sometime within the year prior to their death. Think about that. That's a tremendous statistic. Almost half of all Medicare deaths are on hospice at some point. So hospice is really not a place, but a philosophy of care. A lot of people say, well, where do I go to hospice? Where is it? Well, there used to be one in Halls, but it's not there anymore. Hospice is a special insurance program. Think of it as a special program for the terminally ill. And we've mentioned that hospice must cover all care related to the primary terminal diagnosis. And that does exclude some patients who might benefit. For example, patients who have blood disorders, for example, and need blood transfusions. Very few hospices will cover blood transfusion. There's no prohibition for a hospice to cover anything. They can cover anything they want to. They can cover chemotherapy if they want to. But most don't because of the cost. So you can see that if you're on an expensive chemotherapy drug, maybe an oral drug, it might eat up your daily fee for hospice. It might cost you more to pay for one drug than it would for a whole month that you'd receive in hospice care or hospice reimbursement. So there are levels of care in hospice. Most people are on routine home care. All hospices are required to provide respite care. That's usually a week of in a nursing facility or a residential hospice or even in a hospital where the family can just take a break. Families need breaks once in a while. And then there's this level of care that's not done very often but is done occasionally. It's called continuous home care, and either a nurse, well, it's usually an RN, has to spend 8 hours or more in a 24-hour period. This may be starting a patient on a pain pump, or maybe they have uncontrolled pain or other symptoms, so they're spending time. It doesn't have to be 8 hours continuous, but it has to be a total of 8 hours within a 24-hour period. And then there is this level of care we call general inpatient care. Some of you may recall that there was quite a bit of hospice at one time done within hospitals at the end of a hospital stay. Let's say you come in and you're diagnosed with advanced cancer and it looks like you've got a short time to live. They would put you on hospice at the end of that stay. That rarely happens now because of a change in the rules. You must have a reason to be in a hospital on hospice, something that you can't do at home. And the reality is hospice can do lots of things at home. In fact, in general, they can do about as much as you can do in a hospital as far as pain management and things of that nature. So we don't do much of that. Only a small percentage now of hospice is what's called general inpatient care. Yes, yes ma'am.
On the screen before, you said something about there's an increase in comorbidity. I think you were talking about when people have two diagnoses, because I know one of the real common ones is, diabetes can be very life-threatening, and if you have heart disease or, they're having to choose which to treat.
One of
the
the things about hospice was you could say, well, okay, I'm on hospice for congestive heart failure. And then I'm using BiPAP, for example, for COPD. So you could get the BiPAP covered because it's not a primary hospice diagnosis. That's no longer the case. So you have to include all of the secondary diagnoses that are considered contributing to the primary diagnosis. So in reality, they're encompassing much more than they used to. That is CMS, who makes all the rules. And basically what they're finding was that they got all these people on hospice, and that's a good thing. But then we're getting all this care outside of hospice that's not being covered by hospice. Drugs, drug costs. I think it's like $2 billion a year being spent on drugs by Medicare Part D on hospice patients that aren't being covered by hospice. So basically what they've done is they've expanded primary and any secondary diagnosis that contributes to the terminal illness. And that's a little vague, and it's a little hard to figure out sometimes. Yeah.
Well, you had at the bottom of the previous slide, I apologize, where it said that might make them inappropriate for hospice or not be accepted.
Let's go back.
And I took that, this excludes some patients who have done.
Well, it's primarily patients who might benefit from hospice care who want things like a blood transfusion. And they're not going to be able to do hospice if they want to have a blood transfusion. For example, hematologic malignancies like myelodysplasia, leukemias, and things like that often get blood products, platelets, blood transfusions and so forth, and they may say, I don't want to ever go back to the hospital, I don't want to, except maybe for a blood transfusion, because it does help me feel better. It makes me less short of breath, less tired. But some of those patients, they can't be on hospice unless they decide not to do those things. And there are these, Medicare, CMS has these projects going on around the country where they call it concurrent care, concurrent hospice. That is to say, you could be on hospice and have chemotherapy. And people are looking at that. And pediatric hospice, by the way, does not work that way. If you're on pediatric hospice, by law, you can have aggressive treatment, if you want to call it that, and still be on hospice. It works differently in pediatrics. So there are some who think the adult world should work that way. I think it's pretty good the way it is, although there might be some exceptions that I would make if I were making the rules. For example, I might say, let's pay for a blood transfusion if it actually seems to benefit the patient in a symptom way outside of hospice. But hospice forces people to make choices. It forces them, and a lot of people don't want to make choices, so it forces them to say, okay, my goals are comfort, I'm going to do hospice. If you don't do that, a lot of people will sort of piddle. You see, they'll want to go back and forth, and they won't make a choice. But it may change one of these days. I think people may realize the value of hospice and be able to do more care on hospice. So this talks about GIP. We call it GIP, general inpatient care. It's only 1 to 2% of hospice days total. Requires unmanaged symptoms. Cannot be managed in another setting. For example, complex wound care. Some people might require wound care that would require hospital level of care. The reason a lot of that's changed is, used to, if folks had nowhere to go because they couldn't be cared for at home, we call it caregiver breakdown, or actively dying patients do not automatically qualify for inpatient level hospice care. So a patient who's got uncontrolled pain from cancer, who wants to go home on hospice, maybe they need a pain pump at the end of their hospital stay and you've got 2 or 3 extra days, might be appropriate for general inpatient care. The most common reason for general inpatient hospice care is not pain, it's delirium. Patients get at home and they get wild, the family can't handle them, and they may end up in the hospital on a morphine drip or on an Ativan drip or one of those. And we're going to talk about terminal sedation. Does anybody know what terminal sedation is? Some people call it palliative sedation. Anybody ever heard of that? We'll talk about that in a minute. Here's how hospice is paid. We mentioned the per diem rate. The first 60 days of routine home care now is paid at a higher rate, and it drops on day 61. And then there's a thing called a service intensity add-on in the last 7 days of life, includes a visit by a social worker or RN, that you get extra payment over and above the per diem. So basically what you're seeing is patients who go on hospice require more care at first, and the payments actually go down, but a lot of people who stay on hospice for a while, they become a little more stable. And then the idea is Medicare was looking at hospices and seeing no visits for some people in the last 2 or 3 days of life. Why not? That's when they need us, right? So they've actually incentivized visits to pay extra in the last week of life. Hospices can charge co-insurance, but nobody does that I know of, nobody here in this area. Hospice is done through Medicare Part A, so you can still go to your doctor. If you're on hospice and you want to go see your primary care doctor, they get paid through Medicare Part B. As long as they're not an employee of the hospice directly, you can go see them, they can bill like normal. Room and board on hospice is not covered except short inpatient stays arranged by hospice. Respite's covered, that's arranged by hospice. General inpatient hospice is covered, it's arranged by hospice. But if you're in a nursing home, they don't cover room and board. If you have regular Medicare or Medicare Advantage, by the way, if you're on Medicare Advantage, you go to regular Medicare when you go to hospice. And then if you go off hospice, you go back to your Medicare Advantage. Also, if you're on hospice for lung cancer and you fall and break your ankle, you can go to the hospital, emergency room, get treated for the broken ankle. That's covered by your regular Medicare. Hospice can still see you. You don't have to come off. So there's lots of nuances about the way it works. And then an ER visit, inpatient care, outpatient care, or ambulance services related to the terminal condition are not covered. So if you say, well, I had lung cancer and I've been doing pretty good on hospice for about 4 or 5 months, and maybe I'll get another CT scan to see where my tumors are, that's not going to be covered. So you have to think about all that stuff. So when should you have a discussion about hospice and cancer particularly? And this is one of the things I think is a huge gap, that we don't talk to people early enough. We should target people early. It's never too early when you have, and you know, nowadays when you do chemotherapy in an oncologist office, you have to designate the chemotherapy as palliative or for curative purposes. Supposedly people are told that, but that don't, you know, a lot of people don't realize what that is, or it doesn't sink in. Predicting 6 months or less, not that difficult. We've talked about that. Decline in performance status, weight loss, anorexia, decreased level of consciousness, or progressive recurrent central nervous system disease. Here's an important fact that you have to realize. Oncologists tend to overestimate survival by a factor of 5. Anybody ever heard that before? It's well established. All doctors overestimate prognosis. Oncologists tend to be at the outer limit of that. The average patient with cancer lives only 8 days on hospice. If you're on hospice early, you can avoid non-beneficial hospice or ER visits in the end-of-life phase or the last 4 weeks. So it's an important thing to do. And people now are looking at quality of care in cancer treatment. One of the things they look at is, did you get chemotherapy in the last 2 weeks of life, or radiation therapy in the last 2 weeks of life, or did you go to the ER in the last month of life, or did you get a hospital admission? So some of these quality measures that are being promoted are to try to increase and promote hospice in cancer care. And we place patients in the hospital all the time on comfort care, less so on hospice nowadays. So we say all palliative care is not comfort care. When we're seeing a patient, I hear this all the time. I heard it today actually at the hospital. The patient in room so-and-so is on palliative care. So sometimes when we're seeing patients, everybody thinks, okay, we're supposed to back away. I don't know how many times I've sat down on a floor and one of the medical specialists has said, well, I'm seeing the patient and you're seeing the patient. We don't both need to see the patient. Because they consider that the fact that palliative care is seeing the patient that means I'm not supposed to do anything. That's just not true. Everybody we see is not on comfort care. So when you're on palliative care, you're not on anything any more than when you're seeing a cardiologist. You're not on cardiology. You wouldn't say that, would you? So there's this misconception that when we come, everything is supposed to stop. So all palliative care is not comfort care. All palliative care is not hospice, but all hospice is palliative care. Hospice is a subset of palliative care. So we see patients who have a short prognosis who are actively dying. And you know the patient's actively dying. Some of you have seen that. Many of you have seen that. They're unresponsive. Their respirations are, we call it agonal. They may have a rattle. They may have mottling. But these patients, after their goals have been clarified, are placed on comfort care, and many of those cannot be moved out of the hospital because it's not good to move patients who have hours to live. That's not good. We try not to do that, but it's not always possible to make those accurate predictions, but we try not to do that. So comfort care in a hospital setting generally means stopping blood, sticks, IV fluids, antibiotics, all non-comfort related care and meds. Sometimes there are nuances. We have some people who, for religious reasons, want IV fluids, even though they don't promote comfort at end of life. Some people have a hard time with that. So we may leave a small or slow rate of IV fluids. And we've already mentioned that general inpatient hospice is rare these days. So what's wrong with this one? That's the doctor telling the patient it's not right for you. It should be the patient telling the doctor, I don't want to do all this, doc. I don't want to go through all this stuff. So let's switch gears now and talk about ethics. Any questions about hospice? Anybody ever have a family member at the residential hospice in Halls? Did you? Did you? Several people? What'd you think about it? What do you think about the fact that we don't have it anymore? Terrible. Maybe someday we'll have another one. Or maybe it'll reopen. We'll see. I was medical director there for 13 years, by the way. I worked there for a long time, so it's a good place, or was a good place. So here are some of the ethical principles that we talk about. How are we doing on time? Okay. Patient autonomy, that's very important to palliative care, and I think should be to anybody who practices medicine. I think there are still people out there, physicians I mean, who don't understand that patients have a right to refuse care. A competent adult can refuse medical care. Now, I may think it's dumb to do that, but that's not up to me. As long as they know what their options are and know the consequences, what they are, and so forth, patients have the right to refuse medical care. And then very much a key to practicing palliative care is the principle of the double effect, the ethical principles. Anybody ever heard of that before? That means you're doing one thing with two effects. If I give morphine to a patient with chronic lung disease and their carbon dioxide is elevated, then I'm doing it for the purposes of relieving their suffering if their goals are comfort. But I might speed up their death. I might. There's not a lot of evidence that it does actually, but I might. So that's the double effect. I'm not giving it with the intent of speeding up their death. I'm giving it with the intent of relieving their suffering. This goes back, I don't know, probably hundreds of years, but even in the Civil War they talked about this. You know, you get an injury or a gunshot wound to your leg, and it's bad to amputate your leg, but if it's going to save your life, we're going to amputate your leg. So it's the principle of the double effect. So it's very key to what we do. And you have to kind of understand that to know why we give morphine sometimes to people. And yeah, somebody may say, well, gosh, you just sped up their death. I said, well, okay. I didn't mean to, didn't intend to. My intent was to relieve suffering. As long as your intent is okay, it's ethically okay in my book. And I think that's the way we do it. And then, of course, we have beneficence, do the right things. Not as easy as it sounds. We all want to do the right things. Not always that easy to figure it out. And then we have non-maleficence, which is do no harm. And then this last thing is very important. It's called the rule of rescue. Medicine is practiced this way today. That is to say, anyone who comes to a hospital, for example, or emergency room, it doesn't matter how old you are, it doesn't matter what's wrong with you, it doesn't matter if you're dying right in front of you, you will have attempts made to rescue you unless you or your family or someone that's your agent says, stop, we don't want to do this. And in my lifetime in medicine, that is a switch. That's a change. Years ago, 25, 30 years ago, when I first started practicing medicine, if you were 95 years old and you came to the hospital, implicitly, you would not be put in intensive care. You would likely be made a DNR without all the things we need to go through today. So the rule of rescue is really the basis for advanced care planning. If you don't lay out in some fashion what you want to do or don't want to do, it'll get done. Does everybody understand that? Yes, ma'am.
So I would ask, so the hospital can make the decision about a DNR?
No, not in this world. All I'm saying is there was an implicit understanding that we sort of treated some folks a little bit less aggressively some time ago. I think we've long ago passed that, where it doesn't matter how old you are, it doesn't matter what's wrong with you. Every doctor has to do their thing, sort of. Now, I'm not saying people don't say, oh gosh, I don't think we will do this, and so forth. But there's this implicit understanding nowadays, you're going to get it, whether it's intensive care, ventilator, and so forth, unless you say you don't want it, or your family does. Yes, ma'am.
So if I go to the hospital and I have an advance directive and I don't want
You're going to get it because they probably ain't going to have that advance directive.
Okay, so there's no way for me to,
However, you had that advance directive and you talk to your family or whoever it is your agent, and you know you have a car wreck, for example. People think I fill out this advance directive, it means I'm a DNR right now. No, it doesn't. You know, it asks you questions about quality of life and so forth. So it's a guide. It's not a physician order, it's a guide. So you come to the hospital with a severe accident or whatever it is, and you get on the ventilator, for example, and they say you've got a major head injury, and you're not going to wake up. And then your family says, well, she had an advance directive, and here it is. And you know what? She don't want to live like this, so we're going to take her off that ventilator. That advance directive helps. It doesn't make those decisions. They don't get made when you immediately come there. Now, they sometimes do. If somebody comes in there waving one, you know, with their mother who's 90 years old and says, oh, God, we don't want all that stuff. But in general, a lot of people think, well, if I fill this out and I put this down, that means it's never going to get done. That's just not necessarily true. It takes a time and it's a process. Does that make sense? Yeah, yeah. But it's helpful. It's no panacea. Advance directives are not a panacea, but they're helpful. So an advanced care plan, we call them now instead of living wills, which includes an appointment of a healthcare agent, completion of the advanced directive. Some places have a place to write things down. And there's a bunch of these advanced directives. 5 wishes is one where you can write lots of stuff down. There's the state form, and you can look up. There's all kinds of websites now that have advanced directives, and they're all a little bit different, but they're all similar. And then there's a thing called a POST, called Physician's Orders for Life-Sustaining Treatment. And this really is a physician's order reflecting end-of-life care. So if you've decided you've got an advanced directive, it says if I get a terminal illness or I get in a coma and I'm not going to wake up, I don't want to be resuscitated, then you've got to have a physician's order in a hospital to say do not resuscitate. Now if you're leaving the hospital or you're in an ambulance or you're going to a nursing home or back home and you don't want to be resuscitated, you need a POST form in the state of Tennessee. You got to have a POST form. If you don't have that, they're going to resuscitate you. In fact, we've had a few on hospice that didn't have that, and I think 1 or 2 got at least attempts of resuscitation. Even the family saying, "Oh, we don't want that. Don't do that." They have to do it, or legally they have to do it.
If you're in the hospital and you have a do not resuscitate sign, and they go ahead and do certain things, can they decide what they need to do if there's something else that needs to be done, or they'll just...
You're saying if you have a DNR order, and well, if you have a DNR order, they shouldn't do it. Now, do they make mistakes? Once in a while.
No, I just had a friend that was just in the hospital, had that do not resuscitate done,
Things got done.
and she was not able to swallow her food. She told him she didn't want her food again. She said that. She had a colostomy, catheter, paralyzed on the right side. They kept doing things to her.
Well, DNR doesn't mean do not treat. This means no resuscitation in the event of a cardiac arrest. And it used to, a lot of people implicitly thought, DNR means do not treat. DNR means don't be aggressive. Doesn't mean that anymore.
Then see, a person like me, because of the HIPAA law, doesn't have any right to say anything, is what they told me. I couldn't say anything. Her only family member was in Louisville, Kentucky. She wasn't communicating.
Yeah, we have those issues. Yeah, the issues of who's the surrogate, who's making decisions, and we're going to talk about that just a little bit. So here's about talking about advanced care planning. We talked about how important it is to communicate with your agent. Maybe more important than the document itself is talking to whoever it is going to be your agent, kind of giving them in a general way what you want and don't want. So a properly completed advance directive in conjunction with communication with your doctor and family or loved ones about wishes can be very helpful. Everyone should review an advance directive frequently. For example, if your doctor is talking about dialysis, you ought to think about, okay, I'm going to get on dialysis. I'm probably going to be on this the rest of my life. When do I want to stop dialysis? If I have a major stroke, do I want to stop dialysis? If I'm bedbound and require total care, do I want to stop dialysis? So these are things to think about. Or, for example, a cardiac defibrillator. When do I want to turn that off? Again, if I have a major stroke and other things. So thinking about these things in the event of a major health change is important, and it's important to review your advance directive at that point. And the choice of a healthcare agent, I think, is very, very important. I remember I had a little lady with COPD one time. She had about 5 children, and I talked to her about who she wanted to appoint as her healthcare agent. And she went down the list of the pros and the cons of all of them, and she finally picked about her 4th daughter and said, well, she's mean. I think she'd be the best one. She'll do what I want. And, you know, she had a couple of things, you know, one of her children, she said, oh, they won't be able to make these, they won't do what I want. So, you know, so I think that is important to think about who you appoint. Just don't appoint, you know, your oldest child or your, some people don't appoint their spouse. I mean, you know, that might make them mad, but they don't always do it.
Does physical proximity have any weight in that decision, or we're just all over the country?
Yeah, we are, and I would say yes. It's always the daughter from California who wants to, you know, come in and save the day and do stuff. So I say down there, complete the advance directive to help your family make some of these hard decisions. And a lot of people fill these advance directives out with these misconceptions here in mind, that resuscitation is more often than not successful. We're going to talk about that in a minute. And they think that artificial nutrition, feeding tubes prolong life in advanced cancer, advanced dementia, or any advanced medical illness. The answer is it does not. They do not. It's not about nutrition in those situations usually. And peg feeding, y'all know what a peg tube is, where they put it through the stomach. You can't keep it through your nose and usually leave the hospital with it that way. They don't prevent aspiration pneumonia in people who are bed bound for any reason, really. And then that IV fluids promote comfort at end of life. In fact, they promote discomfort. So we've mentioned some of these things. Let's explore them a little more. Resuscitation, if you're in the community and you have a cardiac arrest, only 10% of those people survive. They may make it to the hospital, but only 10% survive to leave the hospital. Half of those with major brain injury from lack of oxygen to their brain. Not very successful procedure. People do it, of course, but not very successful. There are a few miracles, of course. 20% or less survive to discharge who have been resuscitated in a hospital. 1 out of 5. Again, most of those don't return to their previous level of function. Significant percent have anoxic brain injury. And here's an interesting statistic. If you're over the age of 75, 5% survive. I wonder how many people in the hospitals are over 75. What would you say? Very high percent. I don't know what the statistics are, but at least half, right? In acute care hospitals in the United States today, over the age of 75? A lot of them are over. Significant percentage. If your primary diagnosis is cancer, look at this, 1%. Less than 1% actually. It's point something. Just doesn't happen. So some people have taken these statistics, your question earlier, and said we as physicians should not order CPR, or the default position. You know, the default position is full resuscitation. Some people say that this is too much of a burden for families. You're asking people to make decisions when they really don't understand. And some people say that physicians should take the ball and make these decisions, but hey, you couldn't do that in this climate, in this country today with the legal climate and so forth. You'd be sticking your neck out. It would take a national initiative. And some people have said we ought to have a red light, green light, yellow light. So the 45-year-old with a heart attack who's healthy and working, they're full code. Don't ask them. There's no reason to ask them. Don't burden them with that question. The 95-year-old who's bedbound with dementia, who's in the hospital with pneumonia, they don't need to be resuscitated. That's actually almost medical battery. Think about it. And it's the people in between, the yellow light. And if you need 2 doctors to say that, that's a good idea. You know, if you want to say anybody made a DNR needs more than 1 doctor to agree, okay, that's all right. But that'd take a national initiative. It would take a major public relations campaign and a national initiative. But how much suffering would it prevent? How much money would it save? Maybe enough money to build a residential hospice. So there are lots of people who think in these terms, but actually doing that would be, I wouldn't want to attempt it, certainly not by myself. So as we've talked about, the public thinks most people survive CPR. Not only do they survive it, they go on a date and a movie after they have it done. So anyway. So we've already run off on most of these. How many of you have an advance directive, by the way? About right, maybe 30-40%. Actually, 30% or less have one. Talk about over 65, about 50%. So young people don't, fewer young people have one. But in fact, that's how they got started. You remember y'all probably remember, well, I remember Karen Ann Quinlan, Terry Schiavo, you remember the names. They're all young people that had something catastrophic happen, right? And they all had court cases where their parents or somebody wanted to withdraw. And the courts wouldn't allow it to happen, or it got tied up in the courts. So that's how they started. And as we mentioned, there are studies that show that people who fill out an advance directive, even one they just write down on a piece of paper and have witnessed or signed, have less aggressive care in their end of life. They increase hospice use, they increase hospice length of stays, and it's less grief for the families, less complicated grief. It helps families to, it's something about, you know, if you put it down on paper, it helps people make those hard decisions when the time comes. So the POST form is the only official DNR form recognized by emergency medical services. It's really a medical order. About half the states now have a POST law, and all patients are not POST appropriate. So you were talking about you had an advance directive. You're healthy now. You're not POST appropriate. You don't need a POST form. On the other hand, the patient who's 85 years old and in a nursing home, who's been back and forth to the hospital, and they're a DNR, they need a POST form. And you don't have to fill out all the parts. You've got the part about the resuscitation, you've got the part about goals of care, comfort care, limited care. Yes, ma'am.
Does the post follow you if you have one and then you're discharged? Does it follow you?
It should, yes. You should carry it with you. I tell people to put it on their refrigerator. So if you call 911 for any reason, there it is. Get it and take it with you. Bring it with you to the hospital. It's supposed to go from any medical facility. So if you go from a hospital to a nursing home to a nursing home to a hospital, it's supposed to go with you. And these things are everywhere. There's several problems with them. One is there's no education about them. Nobody knows. I mean, a lot of doctors don't have a clue. And the second part is they're not color-coded or anything. They're buried in the chart. Nobody looks for them. They come in the emergency room. They may have a post form that says DNR, but nobody finds it. Nobody looks for it. So it's got the three parts we've talked about: code status, goals of care, and it's got a part about artificial nutrition and hydration. And it's got to be signed by your physician or a physician extender. And the issues of surrogacy and who makes decisions is common. We have homeless people and other folks who have no family. And Tennessee has laws about that guide these decisions. They're listed in order: spouse, adult, child. And notice it makes no distinction between oldest, youngest child. So if you got 4 or 5 children, you know, it can be an issue. Parents, siblings, and then any other adult relative. And anyone who's willing, who shows care and concern, may serve as a surrogate. We've had neighbors appointed surrogates before. And if all else fails, a physician who's taking care of the patient can be designated as a surrogate with some limits. Usually there's a second physician usually an ethics committee member, who would sign that, agreeing that that physician would serve as a surrogate. And they can make decisions about code status and generally about care, although there are some limits on surrogates who are not designated by the patient to withhold artificial nutrition or hydration, except when those measures just simply are thought to prolong the dying process. And then we have the issue of medical futility that comes up. Physicians often use this, or some people think they use it, just to sort of slow down care or not to do things that families want or request. It's controversial, and the definition is not as easy as you think. I think we know medical futility when we see it, but it's hard to define it a little bit. Palliative care gets involved in a lot of these cases, and kind of communicating with families and trying to sort through that is what we try to do. And of course, the ethics committees get involved. And this talks about artificial nutrition and hydration. It's an emotional issue. Religion and culture are important. As we've mentioned, nutrition and hydration become less important as we approach death. IV fluids don't promote comfort. Tube feedings don't prevent aspiration or improve survival in cancer or any advanced illness, really. And people often ask, well, are they going to starve? Are they starving to death? And of course, I always tell them that they're not starving to death. They're dying of their disease process, and that everyone stops eating and drinking before they die. Animals, humans, everybody. We all stop. But we always offer comfort feedings. If they're awake, even if they aspirate ice cream, we may let them have some ice cream. We don't withhold anything that the patient can tolerate. Now that may be a sip or a taste or a drop on a straw, but we don't completely withhold oral feedings in anyone who can do it. And this is the risk factors for a complicated death. When you're dealing with patients, sometimes it helps to plan ahead. So when you see patients who are dying, who are younger, who have chronic pain, and chronic pain is a huge issue. We see patients who've been on high-dose opiates who are dying. Gosh, it's difficult to control their pain sometimes. People who have had psychiatric illnesses, bipolar, schizophrenia, drug or alcohol misuse is a problem. So anticipation of this, the other thing, some of these complicated cancer syndromes, any kind of cancer that involves nerve root compression, spine, brachial plexus, pancreatic cancer with celiac plexus, you can sort of anticipate. And the pelvic cancers, bladder, cervical, ovarian, some of the abdominal cancers are difficult. So you kind of anticipate, and some of these people need pain pumps. You know, most people die, I think that's important to note, that most people die easily. Most of us will die, we'll just go to sleep, we'll quit eating and drinking, we'll slip off in a coma. We may have a little this or that, and you can drip a little morphine under their tongue, and that takes care of it. But some people die a hard death. Some people go out of this world kicking and screaming, and these are the kind of folks you have to anticipate that they might. It helps you to plan. And this is what we call terminal or palliative sedation. This is when nothing else works, and once in a while we see patients who have intractable suffering or pain, or delirium would be, again, the most common reason for this. This is administered when other palliative treatments are ineffective. It basically renders the patient unconscious. You have to be sure the goals are clear. Everyone needs to understand the intent, not to speed up death, but to relieve intractable suffering. Some consider this the legal alternative to assisted suicide. I would say the principle of the double effect applies. You're trying to relieve suffering, your intent's not to speed up death, but you know you may do that. People use lorazepam, they use Versed, they use propofol, and barbiturates have even been used in these situations. I have participated in this, I would say, many times, particularly at the residential hospice. We did do this. We had a special consent form, though, that we had families sign indicating that we understood, or they understood, the goals were comfort and that our intent was not to speed up their death, but it's possible. So we had that special form to do that. And many of you know that it's called physician-assisted suicide in the popular media. Is legal now in, I believe it's 7 states, if I'm not mistaken. The first state was Oregon. This is their experience with this. From 1998, when the law was passed, until June of 2017, they had 1,857 prescriptions. 1,179 took those and died. Well, 1,179 died. 7 of those regained consciousness, so it doesn't always work. It's usually a barbiturate at a high dose. Only 0.2% of all deaths in Oregon. 90% of these patients who signed up for this cited loss of autonomy and lack of enjoyment of activities. Notice it wasn't pain or suffering. It's control more than anything. Only 26% cited pain. 88% of them were on hospice. 5% of these patients who signed up lived more than 6 months, and actually 11% of hospice patients live more than 6 months nationally. So we all think about that. I would say it's a growing thing. You know, the Supreme Court says it's up to every state. It's legal as long as the states can vote on it. State legislatures can pass laws that says it's okay. You know, I have always said as a physician that I would not be involved in that, and I still feel that way. There are other ways to handle these things, including palliative sedation, terminal sedation if you have intractable suffering. However, I would not fault anyone if they wanted to do it. Because you all see people who, well, we all see patients, or I've seen patients who you think, gosh, I believe I might want to end it if I'm in that situation. I mean, that's just the reality of it. I'm not saying I would. I'm just saying you see people who are in very bad situations. So I guess my thinking, I'm a little more accepting of the idea. What's interesting in Oregon is that people said, well, this would be used by people who are undereducated, poor, and who have no other options. Well, that's been debunked. Look how many are on hospice. Their prognosis is not worse than hospice. It's actually, I mean, it's worse than hospice nationally, in general. They're more, only 5% of them live more than 6 months who signed up, whereas 11% on hospice. So the criteria are not, they're similar to hospice. It's not the poor. In fact, most of these people are highly educated people. Most of them are not poor. There's only like a handful of Medicaid patients signed up for it, like 3 or 4, very small number, and they're highly educated. So the worries about this, that it would be this slippery slope, and you know, we would have people who are the lower end of society doing this just to get out of a bad situation, is just not turned out to be the case. So we've talked about prognosis. We're just about done. Are we okay on time? Everybody got to go somewhere? We've mentioned that doctors tend to be overly optimistic by a factor of 3 to 5. Oncologists on the high end of that. Functional nutritional status continue to be the best predictors. Uncertainty about timing should always be emphasized but not limit communication about dying, and understanding the process will change decisions and help clarify goals. This is a bad death: inadequate pain, unnecessary prolongation, multiple transition of care, we've mentioned, lack of a surrogate, a short hospital stay, and chemotherapy or radiation in the last 2 weeks of life. So here's the old model. Let's look over here. Palliative care model. The old way things were done, you do everything possible, life-prolonging care, and hospice, the Medicare hospice benefit, always think of it's like a wall over here. So you've got to run through it or jump over it to get onto hospice. So we do everything possible without any transition. We think the model of end-of-life care should be, as you get closer to the end of life, palliative care takes on a more important role, and you begin that transition toward hospice. I like to think of that little place there where palliative care and life-prolonging care, it's like a bridge. You can walk up that and gently ease into hospice care. You notice the hospice care box is broader, wider, meaning you stay on hospice longer. And then, of course, we like to think about what happens after death. So that's the model we're shooting for in palliative care. So here's a final thought. Death is not a surgical procedure to which one consents. Nobody wants to die. But it is a process, sometimes protracted, often painful to experience, witness, and accept. The straightforward provision of information is only the beginning of a complex process. Whoops, one more. All right, we're finished. Any questions?